Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Safety Profile of Nivolumab Monotherapy, a pooled analysis of 576 patients with advanced melanoma by Jeffrey S. Weber et al. My name is Ross Camage, and I'm a professor of medicine and oncology at the University of Colorado in Aurora, Colorado. My oncologic specialty is thoracic oncology, and I hold the Joyce F. Chair in Lung Cancer Research at the University of Colorado Cancer Center. In the paper I'm discussing, Weber and colleagues looked at safety data related to nivolumab administered at 3 milligrams per kilogram every 2 weeks, pooled from 4 melanoma studies. These data are broadly important, as nivolumab and several other PD-1 or PD-L1 inhibitors are now entering routine practice across a wide range of tumors, not just melanoma. The melanoma studies they analyzed included the 3 milligram cohorts of 2 phase 1 studies, as well as the experimental nivolumab arms in 2 phase 3 randomized studies versus chemotherapy, Checkmate 037 and 066. In total, data on 576 patients were available. In both Checkmate 037 and one of the phase 1 trials, patients could have received prior ipilimumab therapy, affecting 54% of the total patient dataset. But at least 6 weeks from the last dose of prior ipilimumab was required before the nivolumab could be administered. In the phase 3 trials, patients were treated until progression or unacceptable toxicity, or, in the phase 1 trials, for up to 2 years, whichever came first. The median number of nivolumab doses was 9, and the median duration of nivolumab treatment was 3.7 months. The median patient follow-up was 7.2 months. Treatment-related adverse events of any grade occurred in 71% of patients, and grade 3 or 4 events in 10% of patients. Among the 54% of patients who had received prior ipilimumab, these percentages did not appear significantly different. The most common adverse events of any grade were fatigue, pruritus, diarrhea, and rash, ranging from 25 to 13%. The most common grade 3 or 4 adverse events were gastrointestinal, hepatic, and skin side effects, occurring in 1.2 to 0.7% of patients. Treatment-related adverse events leading to drug discontinuation occurred in 3% of patients overall, most commonly involving colitis, transaminitis, lipase increase, or pneumonitis, each occurring in about 0.3% of the treated population. Treatment-related adverse events thought to have an immune basis that required more frequent monitoring or interventions, for example corticosteroids or hormone replacement, were referred to as select adverse events. Any grade of such select adverse events occurred in 49% of patients, most commonly the skin, 34% of patients, and gastrointestinal tract, 13% of patients. Grade 3 or 4 select adverse events occurred in 4% of patients. The median time to select adverse events seemed to vary by the organ system, ranging from 5 weeks for the skin to 15.1 weeks for renal adverse events. The objective response rate in these melanoma patients was 31.4%, higher than in some other tumor types such as non-small cell lung cancer, which is closer to 20%, with a median progression-free survival of 4.7 months. Intriguingly, the response rate was significantly higher among those who experienced any treatment-related select adverse events, at 48.6%, than among those who did not experience any such events, response rate 17.8%. The response rate was even higher when greater than or equal to 3 different select adverse events occurred, response rate 84.6%, compared to among those who only had 1 or 2 such select adverse events, who had a response rate of 46.7%. Of note, the grade of these select adverse events was not important, as the response rate was no different among those who did or did not experience grade 3 or 4 events, nor did the use of systemic corticosteroids, which occurred in 24% of patients, significantly alter the objective response rate. Unlike with the response rate, in a landmark analysis, which excluded patients who progressed before 12 weeks, there was no difference in progression-free survival between those with or without select adverse events. At its most fundamental, this paper provides a large dataset from which the expected frequency, severity, and kinetics of immune-related adverse events associated with nivolumab monotherapy and the expected use of corticosteroid supportive therapy can now be described. One key caveat about these estimates being that they were generated purely from a clinical trial population which excluded patients with known autoimmune disease, organ dysfunction, or active brain metastases. 85% of the reported immune-related events occurred during the first 16 weeks of treatment. In addition, new events could still occur after more than a year on study. However, the size of the dataset available to estimate late-onset toxicity in this analysis was very small. While prior ipilimumab therapy did not seem to alter the toxicities seen with later nivolumab therapy, reports of nivolumab-related toxicities persisting post-therapy are not unknown. Therefore, treatment-related adverse events could certainly occur after the nivolumab finished and a patient has moved on to other therapies. Depending on the frequency of this, the true toxicity of nivolumab in this report could be underestimated. In addition, it could also be one potential source of confusion in accurately ascribing causality to any later agents administered in a clinical trial setting. Perhaps the most provocative observation in this paper relates to the described associations and lack of associations between immune adverse events, corticosteroid use, and efficacy. Specifically, the positive association between the presence of immune adverse events of any grade and response rate deserves further study. Some temporal analysis would definitely be useful to explore whether a similar link between adverse events and response can be made, for example, at the time of the first on-treatment scan, in order to adjust for the possible confounding effect of patients with response simply staying on drug for longer and therefore getting more adverse events because of that. Similarly, the apparent lack of a negative association between response rate and corticosteroid use has to recognize that a response could occur before corticosteroids are employed, and therefore some kind of landmark analysis looking at duration of response among responders or progression-free survival among those who have and have not started corticosteroids at a given time point may be more informative in terms of truly seeing whether corticosteroids can or cannot effectively abrogate toxicity without affecting efficacy. The landmark analysis of progression-free survival done at 12 weeks after starting therapy did not replicate the apparent link between immune adverse events and efficacy, but whether some earlier assessment, without the editing out of rapid progressors, would produce the same result remains unclear. Overall, this paper adds considerably to our knowledge and suggests multiple new areas for study in the emerging field of clinically active immunotherapy for solid tumors. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.